With all of your permission, ma'am, I'm starting with today's live streaming now. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform, offering a multitude of engineering services exclusively for the doctors. Clarnet is selected to be chosen as a digital partner for this event organized by Karnataka Undergraduate and Postgraduate Ophthalmology Teachers Academy, KUPOTA. So today's focus would be online educational series episode 2. So without any much further ado, I would like to invite Dr. Soumya ma'am to take over. Over to you ma'am.
Thank you, Swastika. And good evening, respected senior teachers, colleagues, friends, and dear postgraduate residents. And I'm Dr. Soumya HV. Very happy and excited to welcome you all once again to the second session of online educational series, a novel initiative of newly formed Karnataka Undergraduate and Postgraduate Ophthalmology Teachers Academy. Happy to have received good appreciation of the first session, which encouraged us to plan the few further sessions. Happy to be one of the founder members of this initiative, which was thought of and now being nurtured by like-minded clinicians for robust academics across the state. So happy to have another founder member, Dr. Mahesh Babu, along with me, Professor and Head of Ophthalmology, Subbaiah Institute of Medical Sciences, an academician, clinician and researcher who has been a strong pillar for this very initiative and has pioneered many such academic programs in the state. So the core vision of our program is to create uniform, high quality academic standards in postgraduate and undergraduate ophthalmology training across the state. So this aims to strengthen the clinical reasoning and presentation skills among our postgraduate students. So we try to create a culture of academic rigor, not passive listening, and to ensure that a postgraduate in one corner of Karnataka receives the same intellectual stimulation and academic exposure as one in any major academic center. So this platform can reduce variability in postgraduate competency, enhance the preparedness for their exams, foster the research thinking and build confident future clinicians and academicians. So let us make this interactive, rigorous, respectful and growth oriented. I now call upon Dr. Mahesh Babu to kindly take over the proceedings. Thank you.
Thank you, madam. Thank you for that wonderful introduction of this session and KUPOTA. Now I'd like to introduce our panelist, chairperson, discussants, mentor for the session. Uh, for this today's second session of KUPOTA. We have Dr. Vasanthi Kotian, madam, a senior professor, Department of Ophthalmology, K.S. Hegde Medical Academy of Bangalore. Madam has vast experience in academics, and Madam has been examiner for various forums, whether it is Medical College, DN and all. So I would like to welcome Vasanthi Madam for this second session of KUPOTA. Welcome, Madam. We
Thank you.
also have with us, we also we have our discussant, Dr. Himalata BC Madam. Madam is Associate Professor in the Minto Eye Hospital, Bangalore. Madam has received has so many awards and accolades to her back. Madam won so many Best Paper awards under COSCON and various other platforms. Madam is a VR specialist at Minto Eye Hospital. We welcome you, Madam, for the session.
Thank you, sir. Thank you, sir. Yeah.
Then we have with us Dr. Uma Kulkarni, Madam, Professor in Ophthalmology, NOPR, deemed to be University Mangalore. She has so many other roles which have cut short. I think I needed 4 to 5 slides for that. So she is a member of ethics committees since 2015, a member of editorial board of various journals, and she has authored various publications and textbook also. More than that, she is a favorite quiz master for all of us, whether it is a district level, state level, national level. Madam is very popular master, and she has hosted a very good number of quizzes across India. I welcome you, Madam.
Thank you so much.
And now we have with us Niharika Shetty, Madam, Professor and HOD, AIMS Bellur, in Adichinchir Institute of Medical Sciences, Bellur. Madam is a chairperson for Board of Studies for Surgery and Allied Subjects. She was also external member of Board Studies for Siddhartha University, Tumkuru. And Madam is also part of, she is actively involved in Institutional Curriculum Committee and also as a part of Faculty Development of Program of the Institute. I welcome you, Madam, for this program.
Thank you, sir. Thank you very much.
Then we have with us Dr. Sangeeta Vivek Patil. She is professor and HOD at Kaza Bandhanavas University, Kalburgi. And she is the mentor for today's session. Her student, Dr. Gazila, will be presenting a case on uveitis, which is a rare case. This case was presented in various platforms and it receives many.
Thank you,
Over to you,
Dr.
madam.
Mahesh. Yeah, thank you, Dr. Mahesh. And I would now request our chairperson, Dr. Vasanthi madam, to speak few words.
Then Dr. Vasanthi, Professor of Ophthalmology, Pontificia Medical College. Good evening to all. I request all the postgraduate students to utilize these sessions, not only this, all sessions of case discussions or different things to enhance their knowledge, because there are various examiners, various ways of asking questions and analyzing the things. Thank you all.
Madam, you are on mute. Soumya, madam.
Muted, ma'am.
Please unmute, madam.
Thank you, Dr. Vasanthi madam, for your words. And I would now request Dr. Gizala, our postgraduate student, to start with her presentation.
Good evening, everyone. So my case presentation, which is titled as Targeted Therapy with Misses the Mark, it follows the diagnostic journey of a patient whose life-saving treatment became a stealthy threat to her vision. So our story begins when a 35-year-old female patient presented with complaints of redness, ocular pain, and watering in both eyes for 6 weeks, associated with progressive bilateral diminution of vision since 3 weeks. Her medical records revealed a different critical point. She has spent her 4 years in a grueling marathon against CML and have been stabilized on imatinib 400 mg for 4 years. So, but when her molecular and hematological response failed to maintain a steady level, her oncologist made a strategic switch to dasatinib 50 mg once daily, which is another potent tyrosine kinase inhibitor. So this switch has occurred about 40 days prior to her presentation. Her general physical examination and systemic examination were all within normal limits. Coming to ocular examination, her on right side, her best corrected visual acuity was 612 with near vision in 8. She had circumcorneal congestion with fresh, small, fine keratic precipitates which is spread over entire endothelium. Anterior chamber was shallow, showing VH grade 1 with cells and flare present. Iris showed posterior synechiae and pupil was irregular, was having seclusion pupillae. Lens was clear and fundus was hazy view. On left eye, her visual acuity was perception of light, projection of rays, accurate in all quadrants. Conjunctiva, she had circumcorneal congestion with the fresh, small, fine keratic precipitates with the pigments dusted all over endothelium. And again, anterior chamber was shallow, but cells and flare were of grade 4 plus, which was more compared to the right eye. Again, Iris had a posterior synechiae with irregular pupil occlusure, but she had occlusure pupillae in left eye, which was complicated with iris bombay. And she also had complicated cataract, and fundus was not visualized. IOP IOP was a 24 millimeter of Hg in right eye, whereas it was a higher side, about 40 in the left eye. Gonioscopy gonioscopy was done using 2-mirror Goldman gonios lens, and it showed 270-degree intermittent peripheral anterior synechiae, that is from 6 o'clock to 3 o'clock in right eye, whereas it showed 360-degree peripheral anterior synechiae in the left eye. CCT showed a 505 micrometers in right eye, whereas it was 520 micrometers in the left eye. As the fundus was obscured because of increased inflammation and cataract, B scan was done, and it revealed optic disc elevation, optic elevated disc margins, and hyperechoic dots seen along the posterior chamber in along the optic disc. It shows that there is a deep-seated inflammation which is spanned throughout the eye. So she was managed with the IV mannitol, which was given twice
Excuse me,
a day
can
for
I
3
hear?
days.
Excuse me. Is the
Yes,
fundus
ma'am.
findings mentioned? I didn't see, I think.
No, ma'am. Fundus was not. It was hazy to view in right eye, but it cannot be visualized in the left eye.
It could not be.
That's why.
Fundus is okay, okay, done. Okay.
May I interrupt?
So base scan was.
Ghazala? Hello.
Yes, ma'am.
Ghazala, I would just like you to elaborate little more on history, because I think we are going with a mindset that you are seeing a CML case. But please take it as a female who has come to you with a redness in eye and following by dimness of vision.
Yes.
Can you just jot down a few differential diagnoses
Go back
at
to
the
the
end of the presenting history? Yeah, let us not get biased with the history that she has of CML. Of course, keeping that in mind, given the presenting history, can you just boil down a few diagnoses? A 35-year-old female, preceding redness of eye, followed by dimness of vision. What can you think of?
So differentials could be an acute iridocyclitis, or an ulcer, a corneal ulcer, or it can be a viral ulcer, or it can be an episode of acute congestive glaucoma. She is having pain and redness both. So differentials of redness in eye associated with pain. It could be acute iridocyclitis or acute congestive glaucoma or corneal ulcer.
Yes. Can conjunctivitis also present with some corneal lesions and dimness of vision with a similar history?
Yes. If it is, if a cornea is involved in conjunctivitis, then it can present.
Yeah. Which have you seen off late cases where you do get a conjunctivitis followed by corneal lesions? You said viral. That is a viral ulcer.
Yes.
So anything where you don't have an ulcer but you still have a dimness of vision? Hemorrhagic conjunctivitis, nummular keratitis.
Yes.
Okay, we do see post-viral corneal
endothelitis, herpes endothelitis.
Yes. Yes, yes.
And also, I would like to add scleritis also should be a differential diagnosis because she is a female, 35-year-old.
Yeah, we do get sclerokeratitis. Yes, yes. So please, at the end of history, Gisela, during your exams, please try to put down some differential diagnosis with the given history that you have. Plus, also do ask some leading questions, which will rule out probably one or two of them. Like say history of trauma, you need to ask. You said history of acute congestive means past history of multiple attacks, headache. So please put down those leading questions in your history when you do present in your exams.
Ma'am, I just want to interrupt. She had past history of 1 or 2 episodes of redness and pain where she got treated from the local ophthalmologist, but she had a recurrent history for which she had come to us.
Okay.
Yes, sir. Yes, sir. So that also has some relevance, Gisela. Please do put it. Such histories will add to your differential diagnosis.
Yes, ma'am.
Okay, because the presenting picture for a 6 weeks history is too disproportionate.
She had complaints since 6 weeks constantly. Previously, that she had 2 episodes which lasted for shorter duration.
Which resolved with medications.
Yes, ma'am. That resolved with medication, but only 6 weeks, ma'am.
Yes, yes.
And she had any history of headache or vomiting or something like that?
Yes, ma'am. She came with very severe headache and vomiting when she had presented to us. That was the first episode.
Yeah. What do you contribute to attribute this headache and vomiting to this disproportionate
pressure?
Yeah. 40
increased
millimeters,
into
your
yes.
record.
Yes.
Yes. Yes. Yeah, please go ahead. From my side, please go. Okay, one more thing is, can I just go back on your examination part, please?
Yes.
Yeah, Cornea. If you can, you should elaborate on exactly, did you see an active KP? Did you see a old KP? Did you see a pigmented KP? Whatever extra information you can give, just try to put on whichever finding you have. Okay. Yeah, you said it is small fine KPs, but is it pigmented? Is it an active KP according to your examination?
There were fresh KPs along with pigmented KPs, ma'am.
Both were there.
Yes, ma'am.
Yeah, and it was distributed all around the endothelium or in a specific
yes,
area?
No, ma'am. All over the endothelium.
So from limbus to limbus, you saw KPs on endothelium?
Yes, ma'am.
Okay.
Like there was no Al's triangle distribution. There was all over the endothelium.
Generalized distribution.
Yes, yes.
So, can you name one of the differential diagnoses if you see a generalized KP, non-pigmented? What do you think? Young
It could be
female.
Fuchs heterochromic uveitis, or it can be viral uveitis.
Very good. Is it unilateral common or bilateral common? Fuchs.
Fuchs is unilateral, most commonly unilateral.
Good. Then here the vision is PL, no? So is correlating with the clinical findings? That's what I was seeing. Left eye.
He had complicated cataract, ma'am.
Was there no corneal edema? Sorry to interrupt. Did you see any diffuse corneal edema with 40 millimeters of mercury pressure?
There was no corneal edema, ma'am, and we had done the central corneal thickness also. It was 520 micrometers.
Okay.
No, but the cornea looks, cornea looks little steamy, no, ma'am? Like here.
Yeah. It looks quite hazy, ma'am. And the vision that you are saying.
Anterior chamber reaction was more compared to right eye, ma'am. That's why it was appearing hazy.
But epithelium edema was not according to you?
It was not. No, ma'am, it was not there.
Right.
Okay. See, provided that IOP is high and reaction is more, what other things you would have thought when the vision is only PLPR?
Even in viral keratitis, IOP will be on the higher side, but reaction will be minimal, ma'am.
Just giving you clue, like is it the disease, whatever the CML you told, no? Or any other disease is confined to the ocular structures, or it is beyond something involvement, any other structure, like
somewhere metastasis somewhere else?
Metastasis or
Masquerade syndromes.
Disc involvement, is there any possibility? Optic nerve?
There are hyperechoic dots in base scan, which is visible.
And also you are telling the mild elevation at the disc level, no?
In the
That's
right eye, ma'am.
in the
left
right eye.
it was. Yes. In the left eye, there were hyperechoic dots.
Okay.
So what can be the cause of that unilateral disc edema that you're seeing there? What all can be the cause? Knowing the history that it is CML, what all you can think of?
As such, a CML can involve posterior segment more commonly than anterior segment, ma'am. And it can also be because of a spread of inflammation from anterior segment to posterior segment, uveitis, involving pan-uveitis. It can involve optic disc and adjacent retina.
Yeah, it can have an infiltration. ONH infiltration is also.
Disc edema.
Disc edema is also a possibility.
Or a papillitis, probably unrelated to this episode, and infiltration is what you should be thinking of.
And also because right eye also she is telling disc edema, ma'am. We should rule out any like raised ICT or any other issues. Either metastasis or a hemorrhage in the intracerebral bleed.
Yes.
We have to take that also for workup. Yeah.
Ma'am, MRI was done, which was normal. MRI was done normal, but we actually advised them to get a PET scan done with discussion with the oncologist, they actually said the PET scan not to be done since the WBCs are within the normal label for her condition. So there's very less chance of meds. So they actually advise not to get the PET scan, but she has some other reports which will help to in the few, like there are a few more slides which will help her where she had the AC tap and all.
Okay, you can
Yes,
go, but we're
yes.
just giving a brief,
At the end of history.
possibilities, that
Yeah,
differential
exactly.
diagnosis.
Yes,
And
ma'am.
because B scan, you showed ONH disc elevation. It's a chronic uveitis eye, isn't it? Like recurrent episodes also, you told there is a peripheral anterior synechiae. So now the pressure is normal. What is the other differential diagnosis in a chronic uveitis B scan ONH elevated? Any other possibility? Like what happens to the, have you heard about ciliary shutdown, no?
Um,
So what will
was
happen?
shut down.
In this case, it's not there, I agree. I mean, in
Hypotonia.
case hypotonia, just keep that
Hypotonia.
also. Yeah, differential diagnosis. If only ONH elevation, chronic uveitis, hypotonia is also one of the cause. Okay. Yeah, you can proceed.
So she was aggressively managed. IV mannitol infusion was given twice a day for 3 days, along with topical medications, which involved the prednisolone acetate 1% eye drops.
Before going to the treatment, do you want to complete your diagnosis? Clinical diagnosis, etiological diagnosis. Because you
And
haven't
the
diagnosis.
fundus, the fundus that you
Yeah.
saw in the right eye, at least that you can.
Because any case, I think in the exams you will not have all these scans and PET scan, MRI, all those reports. You will be having a discussion only based on the clinical findings and history.
Okay.
Right? So what's your diagnosis?
So, as per the classification, it is involving anterior as well as posterior. So, it is a case of panuveitis.
Okay, first of all, is it uveitis or is it masquerade? Now that you know the diagnosis, is it uveitis or masquerade?
As she have this, acute like congestion with flare and the cells, masquerades will present with similar picture, but it is usually described as a white-eyed presentation.
So
They
if
will
you go
not
back
have.
to the image that you are showing, I am not seeing any circumcorneal congestion. If you can see there, there's hardly any circumcorneal congestion. So was this image taken after treatment or before treatment? What is the chronology of this image?
This was taken after starting of the 3 days of treatment.
Okay, so at presentation there was circumcorneal congestion?
Yes, ma'am. She
There
had
was.
circumcorneal congestion.
Okay, fine. So that goes against masquerade, and you think that it is more of uveitis, isn't it?
Yes, ma'am.
What are the iris
ma'am.
findings important to be looked for and serve as a negative
Iris.
finding in uveitis?
Iris, in acute uveitis, iris will be muddy edematous.
So did you say about it?
Yes.
Yeah.
It
Can you go
was,
back to the iris findings?
Yes, ma'am.
Yes. So the only finding that you have mentioned is posterior synechiae. So if you were giving your PG exams, how would you explain the description of this iris in a case of uveitis? Positive findings as well as negative findings.
Positive findings is iris
Go
is
ahead.
looking, iris is appearing edematous and clogged, ma'am. And there are synechiae present, but there are no
Synechiae
atrophic.
you have to describe. It's not enough to say posterior synechiae. You have to describe
Posterior synechiae.
where, location, is it all around or is it in bits and parts? Are they delicate synechiae? Are they broad-based synechiae?
These were not broad-based, ma'am. These were 360 degrees synechiae, ma'am, posterior synechiae. And
okay. So did you dilate the pupil and did you find any changes and in the size of the
as
pupil?
AC was shallow, ma'am, we did not dilate it, ma'am. It was VH grade 1. So we did not dilate it at the time of presentation.
Okay, so for 3 days treatment that you mentioned, what was the treatment after which this image was taken?
Steroids were given.
So no cycloplegic was given?
Cycloplegics also were given, ma'am.
So cycloplegics invariably cause dilatation or no?
Ma'am.
Huh?
Ma'am, they will cause
They
dilatation,
will,
but
isn't it? So you have given a
yes, ma'am.
mydriatic and it has not dilated. That's what I can understand from your. Okay.
Yes,
What
ma'am.
else will you explain or describe in the iris? As a negative finding, it may not be there in this, but any case of uveitis.
What are you looking for?
We
Anything
have
in
to
the
look for
pupillary
any
margin?
atrophic
Yes, very
nodules,
good.
ma'am. Iris
In which
nodules.
condition? In which condition do you see atrophic patches in the iris?
If it is sectoral atrophic patches, it is seen in viral uveitis. If it is complete atrophy, then it is seen in Fuchs heterochromic uveitis.
Okay, fine. Any other finding in the iris, like Madam was
Iris
just mentioning?
nodules.
Yes.
Iris
What nodules? What nodules?
At pupillary border, we can see Koppe nodules. If they are in the peripheral, we can see Basaka nodules. They are mostly seen in granulomatous type of uveitis, like sarcoidosis.
Okay. So, what are the differentiating points for you to say whether a given case of uveitis is granulomatous or non-granulomatous?
Granulomatous uveitis will have insidious presentation, whereas non-granulomatous will have acute presentation. Granulomatous will have more of less marked symptoms like pain and photophobia, whereas in non-granulomatous it will be more marked. Keratic precipitates will be fine type of in non-granulomatous, whereas it will be mutton fat keratic precipitates in granulomatous uveitis.
Okay.
And
nodules.
Nodules.
Iris nodules will be present in the granulomatous type of uveitis, whereas in non-granulomatous there will be absent.
Okay.
And
any difference in synechia?
Synechia will be broad based in case of granulomatous, whereas it will be very
filiform
filiform in non-granulomatous type of uveitis.
Very good. If you answer this, no, the examiner will be happy with, and they will come to know that you know about granulomatous and non-granulomatous uveitis. Okay.
Any other finding? One more finding.
Anything else?
Yeah. A clue like in the diabetic, you see some new vessels in the retina, no? Like that. Is there any possibility?
Neovascularization can occur if there is associated retinal ischemia.
No need. You can see. Iris, sometimes the normal vessels also can appear little congested. And also, if it's a chronic uveitis, if it goes for neovascularization due to ischemia also, global ischemia. Okay, so you have to look for new vessels in these cases.
Okay, one more question I had. In the cornea, in a chronic uveitis case, what are the findings that you would look for?
Cornea, there can be band-shaped keratopathy, ma'am, or
early
can be
band-shaped
corneal
keratopathy.
decompensation.
Correct. Very good. What is the earliest sign of band keratopathy? Where will you look for and how will you look for?
At 3 o'clock and 9 o'clock position, ma'am, there will be calcium deposits in the epithelium.
Okay.
There will be it will be deposited in the an epithelial basement membrane and Bowman's membrane.
Excellent.
And there will be lucid interval at the limbus because the Bowman's membrane is not present over there.
Perfect. Perfectly fine. Okay. So that's one thing that you will have to look for in any case of chronic uveitis. Okay. Did you look for a hypopion?
Yes, ma'am. Hypopion was absent, ma'am.
Absent. Okay. Fine. That's important negative finding also. Okay.
Yes, ma'am.
Okay.
Yeah, and also just want to add a point, ma'am. The CML case can present with sterile hypopion.
Yes, and the pseudohypopion. Yes.
Pseudohypopion.
Yes.
Yeah. That's the tumor cells they tell.
Yes.
It's not uveitis. Yeah.
Yes.
So any non-masquerade causes of hypopion, Vivella? Not the tumor
Yes,
cells.
ma'am.
What can be those things?
Non-muscular, it can be retinoblastoma. It can
That is masquerade, no better. That is cells which are
uh, if there is
for drugs. Okay, whenever we give drugs like IVTA and all, deposits can come into that
rifabutin,
epithelial.
drugs have been associated with uveitis, like systemic drugs like rifabutin or sulfonamides.
Correct.
These phosphorates have been associated,
They are
and
called non-masquerade.
vaccines, systemic vaccines also have been like hepatitis vaccine or influenza vaccine. Topical drugs like latanoprost also cause mild anterior uveitis, or intravitreal triamcinolone or bevacizumab or ranibizumab also may cause anterior uveitis.
Yes.
Yeah.
Gisela, are you the final year PG?
Yes, ma'am.
Yeah. So you will know the differences between seclusio pupillae, occlusio pupillae, iris bombi. Probably there are some first year PGs. So can you describe the differences between seclusio pupillae and occlusio pupillae for them?
Yes, ma'am.
Yeah.
Occlusio pupillae, there is a 360-degree posterior synechiae, which will occlude the passage of aqueous humor from posterior chamber to anterior chamber, thereby causing collection of all the aqueous humor behind the iris and resulting in forward bowing of the iris, resulting in iris bombay formation, which will further occlude the angle, causing raised intraocular pressure in that eye.
So do you want to verify whether seclusio pupillae causes iris bombi or occlusio pupillae causes iris bombi?
Seclusio pupillae is because of fibrinous membrane.
Synechiae. Okay, just a small confusion is there. So you just know that seclusio pupillae is because of 360-degree posterior synechiae, and that gives rise to pathological iris bombi. And occlusio pupillae is mainly because of the fibrinous band in the pupillary area. Okay, just check that. Okay.
And do put the gonioscopy findings, Gisela.
Yes.
Draw a goniogram, mention wherever you saw the synechiae. This is for an AIUS year, but in exam you need to put the goniogram type of synechiae where depicted properly. Okay.
Correct.
And also, if for a young female with hypopyon uveitis, what will be your differential diagnosis? Who presents with?
Young female with hypopyon.
Yeah.
Like HLA B27 is most common cause.
Very good.
Yes.
Reuters and HLA-B27, they present.
Best sets, but more common in males.
So those histories you have to ask, okay, when you're reading this. Those histories you remember to put it as negative history.
Yes.
The central corneal thickness, you think, is it a thinner cornea or a normal cornea, according to you? The CCT that you have mentioned. It's normal. The right eye 505. What happens when there is a thin cornea? On the IOP, I mean. On the IOP, yeah. What does it do to the IOP?
It requires less pressure.
No, ma'am wants to know the correcting factor. Do you want to put something like that?
It underestimates intraocular pressure.
Falsely low intraocular pressure.
Yes.
Compared to a thicker cornea.
Yes.
Okay.
Okay, so here the IOP is high because of what type of glaucoma?
Secondary angle closure.
Okay. Can uveitis also cause open angle glaucoma? Secondary open angle glaucoma.
Yes, ma'am.
What is the mechanism?
If there is a trabeculitis or because of deposition of inflammatory cells in the angle.
Very good.
Can cause raised IOP.
Okay. What is glaucomatocyclitic crisis?
Steroid induced.
Okay, steroid induced. Okay, very good.
Even the inflammatory cells.
Glaucomatocyclitic crisis
is
glaucomatocyclitic crisis is nothing but Posner-Schlossman syndrome, ma'am. It is
okay. It is
Posner-Schlossman.
What is the relationship of reaction to the IOP in Posner-Schlossman?
IOP will be towards a higher side.
Yeah, but what will be the reaction?
It is a unilateral with raised IOP with the minimal AC
Anti-reaction
reaction.
reaction.
Correct.
What is the etiology for it? Etiology for it, beta, Boston-Scholz में. And nowadays they have come down with viral etiology as a cause. Okay, Boston-Scholz में.
Okay.
No longer an idiopathic hypertensive iridocyclitis.
Yes.
The B-scan showed any vitritis or anything?
Not prominent cells, ma'am. Only along near the optic disc hyperechoic dots were seen.
Okay, with a small pupil, you are not able to appreciate the disc, like fundus, if you attempted with slit lamp.
No, ma'am. It was very hazy to visualize it.
Okay. Now, what other differential diagnosis? A normal patient, if you see like this in ONH elevation, leave apart uveitis eye.
Any other causes for this?
Any other causes?
Papillitis.
Good.
Like, yeah, AMD and all, we see some drusens, no? Is there any other possibility like that in the disc?
Optic disc drusen, no?
Yeah, very good. Oh, yeah, possibility. I'm just telling. Because vitreous cavity here is not much of any reaction, no, in the right eye.
Looks absolutely anechoic actually. So
Mm.
if you want to enhance the opacities on a V-scan, what do you do? What settings you change, Gizala? If I want to enhance opacities to differentiate vitreous hemorrhage from vitritis, what settings?
Posterior aspect echo should be enhanced. That's what ma'am telling compared to anterior.
No, ma'am. I don't know.
TVG, have you heard? Tissue gain velocity. One option is there where you can suppress the anterior aspect of the B-scan echoes so that any posterior subtle we are missing, we can enhance those echoes. Okay. And in the left eye, you are seeing all other findings. No, that appears to be increased retinocoroidal thickness also increased. Yeah. And some echoes in the vitreous cavity. And in the periphery, grossly, I feel there may be some
fluid also.
Yeah, it looks like that. I'm not sure. Sometimes we don't keep the probe properly, also, we'll pick that. So, what are the other features you suspect in an UVEITIS side? I'm telling no need to be CML only. In an UVEITIS side B scan. What are the
It can be say retinal detachments, serous retinal detachments, or choroidal thickening, or there can be vitritis if there is retinochoroiditis.
Serous retinal detachment, female, what will you think of?
Commonly
VKH.
Very good, very good. Yeah, that's what. VKH, and as previously I told, scleritis, you may see. Yeah. That's also one of the differential diagnosis. And if it's a CML, what are the other possibilities of posterior segment? I mean, B-scan findings.
There can be leukemic cells infiltration of retina.
Many
as
patients.
There are fundoscopy findings, ma'am, like rot spots. And,
good. Yeah. So, because of that also, there may be risk of vitreous hemorrhage also, no? There may be breakthrough hemorrhage. You may see that. Exudative RD, you may see. As you told, ONH infiltration possibility is there. And choroidal infiltration. Okay.
Yes.
So if you're thinking of VKH, what are the other ophthalmic signs that you would look for?
There can be nodules called as Ballenfick nodules all over the fundus, and associated systemic features like sensorineural hearing loss, scoliosis, vitiligo.
Very good. Scoliosis,
what
vitiligo, alopecia. Yeah. Huh?
What type of anti-uveitis leakage will cause?
Granulomatosis.
Yes, granulomatosis.
Correct. Okay. What about sarcoid? Does sarcoid
Sarcoidosis
also cause
also
uveitis?
causes, yes,
Yeah.
ma'am. It causes granulomatous type of uveitis.
Okay.
It will have iris nodules.
Okay.
Mm.
Okay. Can cause chronic also, chronic iridocyclitis. One of the differentials should be that. But in India, what is the most common differential for uveitis, which is bilateral?
Tuberculosis.
Huh?
Tuberculosis.
Yes.
Tuberculosis.
So what clinical history is important to rule out tuberculosis?
Persistent cough and evening rise of
Yes.
temperature.
So all this has to reflect in your history in case of uveitis, okay, in the exam.
Yes, ma'am.
Okay.
Yes, ma'am.
So what is the
Yes,
history
ma'am.
you want to rule out?
Loss of weight or
Tuberculosis
something.
is loss of weight, fever, and persistent cough. And
Yes. And for
Loss of
ankylosing
as for
spondylitis, you
tuberculosis,
said?
for
Yeah,
ankylosing spondylosis, back pain early in the morning.
back pain. Pain may not be there. You can ask for stiffness. So does it take
Stiffness.
a long time for the lady to get up and start walking without any stiffness? So that you need to ask. Okay. Then
Yes, ma'am.
anything
Yes, ma'am.
else? For Behçet's, what is the
For
clinical history you would like to ask?
like genitourinary complaints like genital ulcers and oral ulcers.
Yeah. For reactive arthritis?
Like psoriasis, dermatological.
Okay.
The
Okay.
skin lesions we have to look for.
Okay. Okay. So all this has to reflect in your clinical
Negative
history.
history.
Yeah,
Yes.
negative history. And each one say why. In the exam, if you get the same case, you'll have to say, I have taken all this negative history and say why you have taken each one. Okay, group of symptoms,
Yes, ma'am.
say together to rule out tuberculosis, to rule out ankylosing spondylitis. So that will help.
Yes, ma'am.
Okay.
Yes,
So you also said it is pan uveitis, right?
ma'am.
So what are the causes for pan uveitis?
Like masquerade syndromes.
So that is not
Like
uveitis, right? Okay. Okay. It mimics
VKH,
uveitis. Okay.
sympathetic ophthalmia, VKH,
Okay.
tuberculosis, sarcoidosis,
Okay.
Viral.
virus.
Viral also. Yes. Okay. Good.
Toxoplasmosis.
I think, yeah. Okay. Good. So don't
Yeah.
forget tuberculosis. That's very important. Tuberculosis,
Yes.
sarcoidosis, don't forget. To begin with, you can start
Yes,
with
ma'am.
tuberculosis, particularly in India.
Yes, ma'am.
Yeah.
Yeah, you can go for the
Go ahead.
treatment.
Go ahead.
Yeah.
Go ahead.
IV mannitol infusion was
Can't hear you. Or
Your voice is not audible, Gizala.
okay. So for all the other PGs, I think till she comes back, we have to give a
Yeah.
yeah. We can say that negative history is very important in all cases of uveitis. Even if you know the final diagnosis, you need to rule out all other possible causes of uveitis in history itself. Even in examination, don't stick only to the positive findings. Give importance to all the relevant positive findings. Since it is, say, for example, in this case, because it is chronic uveitis, you must mention that you are not seeing any signs of band keratopathy. You're not seeing any hypopyon. You're not seeing any new vascularization of the iris. I think this is also very important in all cases for a complete presentation. Okay, so you'll do well in exams if you give all the positive as well as relevant negative findings and history in exams.
Yes.
Any inputs from your end, Dr. Niharika madam? Like the points what Dr. Uma madam said, but they're really very vital, because even
Yeah.
though we are not we have to look at the causes, all the causes of uveitis. The mentioning of negative histories especially, I think the examiners would really look forward.
Yeah, the most elaborate part of examination in any uveitis case will be the history. And so negative history, keeping the age, keeping the presenting findings, the gender, everything she should have mentioned.
Yes.
Even on the examination part, I think emphasize on conjunctiva, cornea, all those which will have findings.
Yeah, lid also. I mean,
Yeah,
start
eyelids
from the
also.
lid slats, including generalized lymphadenopathy. So
Mm.
they should have
Systemic
evaluated,
examination.
particularly for bilateral cases for lymphadenopathy.
Yeah. And as ma'am said, negative history, no presence of oral ulcers, no
Correct.
presence of should be mentioned
Yeah.
in general examination. And a complete diagnosis, because this case actually has cataract, it has glaucoma, it has uvea. It has discussion for everything actually.
Yeah. And also the clinical findings sometimes in uveitis can be chronic on acute. So some features of chronic will be there and some features of acute, like recurrent episode of attacks. It will be not very clear-cut findings will be there, like it may masquerade.
Yeah,
And
for
one
this
more
patient with
investigation. Yeah.
this patient presenting with occlusio pupillae with 3 attacks, shows quite severe form that she must have had in the past.
Yes,
and at
madam.
least
And
some
we-
history need to be elicited of what form of drops were given and all those things in the history can be elaborated.
And UBM also is one of the diagnostic thing which we can use wherever available for to look for cyclitic membranes, ancillary body status and all for any uveitis in general. I'm telling it will be useful.
And before going for treatment, I think even the investigations are important. What are the investigations? Blood tests to be done, ocular tests to be, because she has mentioned about EB scan. She has, I don't know, I think by EB scan, MRI, PET scan, all those came. But I think what was missing was the blood profiles, the blood tests. Yeah, including VDRL. I think nowadays the syphilis is also increasing, so prevalence, and you are getting cases of uveitis with syphilis cases. So it's important to evaluate all the systemic infections.
Yeah, and ruling out infective etiology remains the primary.
Yeah, I think she's back. Are you back, Gisela?
Yes, ma'am. Yes, ma'am.
Yeah.
Gisela, please elaborate on the systemic investigations before you go down to the treatment profile.
Yes, ma'am. Yes, ma'am. So on OCT of right eye was done as left eye was having cataract. So only right eye was done. It showed cystoid macular edema.
So, Gisela, in the exam, sorry to interrupt you, go back because we are thinking of you as a PG presenting in exam, and along with you, many other PGs will also learn. So, instead of directly giving the diagnosis of cystoid macular edema, please describe what you're seeing and then say that it is a case of cystoid macular edema. Yeah.
Yes, ma'am. So, OCT of right eye was done. It showed multiple cystoid spaces involving outer plexiform and inner nuclear layers. So which is suggestive of cystoid type of macular edema.
Cystoid macular edema. Okay. Okay, go ahead because this is important. Others are learning with you. Okay, from you.
Anything in the vitreoretinal interface you can see there? Does it look elevated?
This side, ma'am.
Yeah. But the other entry is also looking partially in the picture. So we are looking for tractions on the macula when we are looking. Okay, so just because our treatment is going to help our patient or not, so we want to look for any tractions that are there. Not very apparent here, but do comment on the vitreoretinal interface.
Retinal interface. So,
okay.
And if it's a uveitis eye, sometimes vitreous cavity, we may see low reflective multiple echoes, ma'am. That also suggests there will be reaction like.
Yeah.
And we have seen like that for many decades, so I just thought I had on that point.
Yes, ma'am. Any echogenicity in the vitreous cavity, vitreoretinal interface has to be mentioned, Gisela. If it is your, especially in a uveitic case, It helps us to differentiate, are we dealing with retinitis, retinochoroiditis? Look for that also.
Okay. Okay.
Was the OCT of the ONH done? No? Okay.
No.
Okay. So that would also help you in understanding what is happening at the disc.
Yes, ma'am.
Yeah.
Yeah, I think she has done FFA, ma'am. FFA picture she
FFA is
showed.
done?
Okay.
Yeah.
Yes, ma'am.
Hmm.
So fundus fluorescent angiography, it showed disc staining and with a leakage at the macula, along with multiple hyperfluorescent lesions in all quadrants, which was noticed in the late phase.
So they were increasing size or remaining same throughout the angiogram? Were they increasing?
Ma'am, they were increasing,
Suggestive of leakage?
suggestive of leakage.
Yeah, if there is a choroidal lesion in an uveitis, what is the characteristic FA features you get? Like initial?
Hyperfluorescent.
Hyper or hypo?
Hypofluorescent.
Good.
Yeah.
Hypo followed by hyperfluorescence.
Hypo.
Good. This looks like mid-phase we are seeing hyperfluorescence. No, ma'am. Corresponding hypo, I'm not able to
We are
appreciate.
not getting actually.
Initial, yeah. And definitely there is a disc margin blurring, elevation. So
And leakage more than staining is what it looks like at the disc. Looks like an inflammatory leakage at the disc.
Yes, ma'am.
More than a late staining of the disc. The margins.
So Gizala, how do you differentiate between staining and leakage in an FFA?
Leakage will
along the
increase in
phases,
size.
Gizala, what will happen along the phase? Increase in.
Yeah,
Leakage will increase in size.
Correct. Yeah.
Yeah.
And what phases
intensity
you'll
and the size, both the intensity and the size will be increased. Okay. Okay. Next slide.
Even
Like all infective causes or tuberculosis, MAN2 test was done, ma'am. VDRL test was done, ma'am. And ACE levels were done, ma'am. HLA was done. Everything was had come negative, ma'am. So everything was ruled out.
Any
infective causes and autoimmune causes were ruled out. Huh, ma'am?
What did you suggest to rule out TB? What all tests did you suggest to the patient?
MAN2 test we have done, ma'am.
Yes.
Then for sarcoma, huh, ma'am?
Yeah. Any other test for TB?
Quantiferon gold test. And chest X-ray also can be done. Chest X-ray also was done, ma'am, for the patient.
Yeah. You please stick to the COTS trial. So they have given what all to be given, and we follow that. We want to any specification. What tuberculin? How much international unit tuberculin do we specify, or it is done with any generalized? How we do?
0.15 ml of 23 units.
It is one tuberculin unit. Okay, as against it will be done with 5 or 10. So you specifically ask for one tuberculin unit for the MAN2 test.
23 strain is used for.
Yeah, nowadays
about after injecting intradermally 48 to 72 hours, after 48 to 72 hours, the reaction is measured. Induration is measured more than the erythema. So more than 15 mm is significant. But if the patient is immunocompromised, then less than 15 mm also should be considered significant.
Okay. Yes.
Yeah, because one of the most common DD is sarcoid also, no? So some pulmonologists I've seen do bronchoalveolar lavage also they do. They take a sample, and that also one of the diagnostic which you can consider. Yeah.
Okay. Continue.
Next slide.
The aqueous aqueous aspirate cytology was done, and it showed no CML cells.
Yeah, but fundus picture, you do see some lesions there in the fundus picture.
Yes. Yes. So fundus of right eye, it showed blurred disc margins, macula foveal reflex was dull, and with the multiple subretinal discrete yellowish lesions was found in all the quadrants. Multiple discrete subretinal lesions was found.
They were subretinal or intraretinal? It looks
There
subretinal.
was subretinal, as they are yellowish, so subretinal.
How do you differentiate intraretinal from subretinal? Any lesion. Don't take this. Any retinitis.
Subretinal lesions will be yellowish and more demarcated, and retinal vessels can be seen over the lesion. Whereas retinal lesions, there will be less demarcated blurry margins, and there will be whitish, and retinal vessels will be distorted over the lesion. Obscured over the lesion.
Yes. Okay.
How do you describe this? Does it look pale now? Is the disc pale?
Appearing to be
the
pale
photograph. Yeah, at least in the photograph, it's appearing quite pale.
Yes.
So how do you explain that?
Long-standing papillitis.
Itis. Inflammatory conditions will always have hyperemia. So
no, like long-standing
does it look like secondary optic atrophy to you?
Sequelae of long-standing inflammation can cause optic disc pallor.
Okay, so what type of optic atrophy will you call it?
Secondary optic atrophy.
Okay, as a result of long-standing papillitis.
Long-standing papillitis.
Okay. Have you done fields in this case?
Visual fields. When patient was.
At least the confrontation. So in the exam, just try to do at least the confrontation test if you can't do perimetry. Because if you're saying optic atrophy, then you have to show some visual loss, right? Isn't it? Okay.
We had done twice, ma'am, but unreliable fluids, like much of fixation losses were coming, ma'am. She was unable to do.
Okay.
So I have not included in it.
Fine, no problem. You're doing fine.
Yeah.
You're presenting well. Don't worry.
Very good. Yeah, very good.
And then second follow-up was done, which is about 1 month. So visual acuity was maintained in right eye, about 6.9 with maintained IOP and patent PI. But in left eye, visual acuity again was dropped from 624 to counting finger at millimeters with raised intraocular pressure about 40 mmHg. On examination, PI was blocked and hence repeat PI was done in the left eye.
Okay.
See, how will you?
Yeah, go ahead.
Yeah. Please continue, ma'am.
No. Just wanted to ask her for the clarity of the other PGs. How do you say that the PI is patent?
Yeah, same question I was asking.
Okay.
Yeah, please let her answer.
On retro illumination, we have to see a light coming out. Retro illumination, we have to see the reddish haze of the fundus, reddish glow of the fundus from the PI, ma'am. If we are able to see, then the PI is patent. But if we are not able to see, that means PI is blocked.
Okay, fine.
So any special measures that you will take when you're doing a PI for a uveitic patient? Do we just follow how we do for angle closure glaucoma, knowing that this is an inflamed iris?
We have to control first inflammation, ma'am, as there is increased risk of hemorrhage following PI.
Yeah.
So first,
Yeah.
inflammation and intraocular pressure have to be uh, controlled now.
You're doing it to reduce intraocular pressure. Yes, ma'am.
Inflammation need to be controlled.
Yeah, very high risk of closure will be there. These
Very high
PI
risk of
uveitis,
closure.
yeah.
So you do multiple PI actually. You prefer to do multiple site PI because it is very likely to close given the inflammation. Yes or no?
Okay. Yes, ma'am.
And some people do argon with, yeah, argon,
Associated with to expand the ostium.
yeah, just to get some coagulative effect as well and to maintain the patency. And a close follow-up, knowing that it is likely to close.
And intense steroids also, ma'am, to control the inflammation post procedure, post PI.
Yes. Yes.
Okay.
So as she had a repeated episode of inflammation, so we consulted her oncologist about her condition, and her oncologist again switched her from neratinib to nilotinib 600 mg. So recent follow-up, a patient was maintaining visual acuity of 6/6 in right eye with good intraocular pressures and patent PI. Fundus was revealed well-defined margins, and foveal reflex also was present. Whereas in left eye, visual acuity was stable at pointing finger at 1 meter, but IOP was maintained at 16 nm of Hg and patent PI. But anterior cyclic was developed temporarily. And fundus
one with the cornea that is shown, that is the anticyclic. In the mid periphery of the iris.
First presentation, there were only peripheral anterior cynic, but now to the cornea also she had developed cynic. Mid periphery.
And did you check gonioscopy? You should do, okay? Just because your PI has worked wonderfully for a 40 mm IOP. So that was not a synovial closure, just a appositional closure has worked. So you will be able to see the angles open post because this PI has worked for her.
Yes.
So do a check gonioscopy once you follow up the patient next time. Means whenever we follow up post PI, I mean to say.
Ma'am, right eye oppositional closure was there. Ma'am, left eye there was complete more than 270-degree synechium.
But it responded to the PI, ma'am?
Yes, ma'am. Actually, we reduced the IOP by giving IV mannitol, made the cornea clear. Means it was slightly hazy, and then later on we did the PI for the second follow-up.
For this left eye now, what type of cataract we usually get in a uveitis eye?
Complicated cataract.
But some terminology is there, no?
It can be uveitic induced or steroid induced, ma'am.
Very good.
It is because of uveitis. Toxins and lack of nutrition will cause
that's a mechanism.
Most commonly it is steroid induced posterior subcapsular cataract.
Very good.
Breadcrumb appearance.
Very good, very good. You would like to operate on this eye now for cataract?
The eye should be in the quiescent stage for minimum period of 3 months. And then we can plan for cataract surgery, and we have to see her systemic condition also. We have to give preoperatively oral steroids and continue on the tapering dose postoperatively. And we have to plan cataract along with glaucoma surgery. First, cataract surgery to be done. It should be a sequential. First, cataract surgery to be done. Then, after that, trabeculectomy or glaucoma drainage device can be planned.
Very good. What is the most common complication whenever we operate on uveitic cataracts? Which
posterior capsular opacification.
Post-op.
If trabeculectomy is combined with cataract surgery, then there is high chance of blood failure because of increased
Because
inflammation.
this size may land up with ciliary shutdown. There will be high chance of post-op hypotony.
Hypertonic.
So that complication, and as already suggested, UBM better to do, see the ciliary body status, cyclitic membrane,
Cyclitic
everything, and then
membrane.
we have to decide, okay, for surgery.
If there is cyclitic membrane, it can cause tractional detachment and hypertony.
Yeah, good.
In this case, the pupil is only around 2 millimeter. What difficulties will be encountered during cataract surgery, and how do you manage them?
So first, preoperatively, we have to give steroids. Then intraoperatively, we should go for subtenons or peripalpal block. Topical block cannot be employed. And we have to release first the Sinike. Then we can a bigger and iris hooks have to be used for
So you have
proper
to
dilatation.
emphasize the use of viscoelastics here. What viscoelastics will be preferred? Okay.
Yes.
Okay.
Like
Synecular.
then syneculisis to be done. Then iris hooks to be used for a proper dilatation, and large rexes to be done, and IOL preferably hydrophobic acrylic.
Very good.
Acrylic to be used. Hydrophilic can be used, but it should be square edged to minimize the posterior capsular opacification.
Yeah, very good. Or else there will be lot of deposits over the IOL also. That also will obscure the vision. Okay. Okay. Next slide.
So, seeing all these findings and investigations, three differentials were noted down. First is tyrosine kinase inhibitors induced panuveitis with secondary angle closure glaucoma in both eyes and complicated cataract in left eye, or idiopathic immune-mediated uveitis, or Posner-Schlossman syndrome. As it is a bilateral chronic condition and marked in anterior chamber reaction, so Posner-Schlossman syndrome was ruled out. As a patient was doing better after changing her tyrosine kinase inhibitor drugs, so idiopathic immune-mediated uveitis we ruled out from the list. So as there is a previous one case report of imatinib induced uveitis, so we thought it is possible relation as she improved with the change of drugs, so we thought possible relation between this. And also at the time of episodes, her molecular response was stable. She didn't had in the active stage, her CML was in remission stage, it was not in active stage, hence, and AC tap also showed no leukemic cells. So ocular infiltration of CML also was ruled out. Yes.
Very good. I think more questions can be asked in case of uveitis regarding immunosuppressants in the use of uveitis, role of systemic steroids, role of topical steroids, duration, the sun classification. I think you need to know verbatim sun classification and methods of looking for aqueous flare and cells, what should be the illumination, what should be the size and all that. So with that, I think you should be doing very well in the exam also. Okay.
Yeah. Now, instead of this drug, whether they change the drug or they just stop the drug, in tyrosine kinase inhibitors?
They have changed, ma'am. They have changed, ma'am. She was in imatinib for 4 years and she was stable, but her molecular response was not stable. Then they changed from imatinib to dasatinib, and this change had occurred 40 days, about roughly 40 days prior to presentation to us. So while she was on dasatinib only, and again she got a second episode of inflammation where she had blocked PI and all. So again we consulted her oncologist. Again he changed from dasatinib to nilotinib, and now she's stable on nilotinib.
No, it's a very good message. Like whenever we see an uveitis, the two masquerade uveitis like this. So either the treatment part, not only the disease, the treatment, what drugs we use can also damage the eyes. And most commonly, CML patients can present most of the time due to ocular manifestations. Like what they tell, literature wise, 80% may be the ocular manifestation as an initial finding, then they diagnose the systemic manifestations. So it's very important to note, and a very good case which has been presented. We are happy for it. Any other points, ma'am, you would like to add, Dr. Niharika, ma'am?
Did you stop on the topical drugs, Rizala? She's off the topical medications completely currently.
She is using anti-glaucoma medications, topical anti-glaucoma medication she's
only on that, not on any anti-steroids.
No, ma'am, no.
And she is in complete remission for the uveitis.
Yes, ma'am. Yes, ma'am.
Just for the completion, what is the general ocular manifestations of CML? Like, can present like?
CML can present, involve posterior segment, anterior segment. Posterior segment, it can cause leukemic infiltration of retina. It can present with rod spots. It can
anemia like picture, yeah.
And whereas anterior segment, it can have a picture of anterior uveitis. It can have leukemic
That's
cells
what
in the
just I
anterior
wanted.
chamber
Yeah.
causing
One sec.
hypopyon.
Yeah, I just want to add on a point. Like as a postgraduates, whoever sees an anemic retinopathy like picture, please work up for all the blood profile. It's very important. Complete hemogram, peripheral blood smear, at least the basic things to be done. So we should not be very casual. Either it can be a simple anemia or an anemic picture due to some other pathology. Okay. Please go ahead. Yeah. Then other findings. Hello. Yeah, you can go. You can go ahead. Yeah. Tell other
Anterior
findings.
chamber, anterior chamber, it can have anterior uveitis, or it can have a hypopyon if there are leukemic cells.
Good.
Okay, I think that sums up most of the
good presentation.
Yeah, Rizala, good
Good
presentation,
learning
good
for
case.
others. Yes.
Thank you, ma'am.
Congratulations to the merit of choosing this. Thank you, ma'am. Thank you. Actually, I just wanted to add. Last week, she had presented in All India UVEITIS Society competition this case. She
Very
also
nice.
had a good applaud there for the good presentation as well as all the photographs, investigation photographs, and the collection of all the documents.
Yes, ma'am.
It was a rare case, ma'am. We are trying to make it as a published as a case report. Since there are not many reports on this, only one or two reports on this drug.
Drug-induced,
Yes,
Yeah,
ma'am.
it's a very
Especially on
nice
this
case.
drug.
And that too
It's a
presented with a
nice
pan
case.
uveitis, all the layers.
Yeah, it's an eye opener. Like we need to look far beyond what we are looking for, and a
Yes, ma'am.
careful history taking, and what medications the patients have been put, and what all the problems they have. Many people we just go ahead, see with the torch or an indirect, and conclude for uveitis. So
Yes,
it's
ma'am.
a very nice topic which we have selected. We are happy
Yes,
for
ma'am.
it. Thank you,
Thank
ma'am,
you, ma'am.
for
Thank
sharing
you,
this.
ma'am. Thank you, ma'am. Thank you very much. Thank you, all the
Actually, a
moderators.
tough case to
Yes,
Yeah.
ma'am, very tough.
Tough
I
case
had
to
a very tough time so that she was economically very poor. For every time we need to admit her free of cost, give all the drugs. For 2 days, we need to give her IV mannitol, follow up with the anti-glaucoma medications, then do PI. And patient also was very much, she was very much reluctant because of the CML as such. She was not able to come out. As a female, it was so difficult. But now when she came last week, she followed up us. She was really looking good, healthy, and she didn't had any repeat symptoms.
And happy.
Yes,
well
ma'am.
managed.
Very happy.
Well managed, ma'am.
Thank you.
So you
Thank
have
you very
managed.
much, ma'am.
You have managed a CML case, ma'am.
Thank you very much, ma'am. Thank you
Along
very
with the
much.
oncologist. Yeah,
Thank you.
congratulations.
Thank you, ma'am. We also want to thank our oncologist who has been regularly in contact with us.
Yeah,
sure.
Over to the moderators.
Any comments from any take-home messages or anything from the discussions from our mentor and our chairperson, Dr. Vasanthi Madam? Anything you want to just add to this?
Madam is
I
there
think
online?
Vasanti is muted.
I think Niharika ma'am can conclude 2-3 points. Yeah, sure.
Yeah, ma'am. Any UVITIS case, as we already, I'm just reiterating, history forms a very crucial part. And after history, please emphasize on the findings, not only the ocular findings, but also the systemic findings, and a very curated investigation, rather than just generalized investigation. I think rightly done in this case, whatever they required, they have just stuck upon to those investigations. Probably in your exam, our postgraduates might enumerate the list of investigation, but when you're practicing, we might have to think the cost, the weight on the pockets of the patient, and hence you should be able to curate the investigation as per your clinical diagnosis. Is what I would
Yes, ma'am.
suggest.
And also all the
Most of the tests are expensive. Yeah. Yes, ma'am.
No, you conclude, ma'am. Then I will speak. No issues.
Most of the tests are being expensive, and so keeping that in mind, you should be able to point out some few investigation which you would like to do for. That is what we are looking at when we are examining in the exams.
No,
But overall, well presented.
I just wanted to stress on the art of history taking for all junior PGs, ma'am. Postgraduate students, please spend some time. It not only helps for the patients to get into confidence, it also helps us to lead to the diagnosis. So please spend some time and take a proper history. And also indirect history, like whether they are on medications, whether they had similar episodes, like some leading questions we need to ask so that they open up. Sometimes they will have so many tablets, they may not show to all the tablets to us. And also we should have patience to look and see all the old records and all the tablets they are on. That also helps us to solve many cases. Like that's my suggestion.
Dr. Uma, ma'am, anything else you want to add?
Yeah, just want to add that in the exams, if you get a case of uveitis and you know the diagnosis relevant to that, take it as a general approach to uveitis, present it as a case of uveitis. You don't know the final diagnosis, and then elaborate on the investigations and findings. So that's a very important thing, because in exam, if you know the diagnosis, you'll straight away look at only those findings which you feel are important, and you'll miss on many others. So take it up like that. All the best to everyone. That's all.
Thank you for those
something
words.
else
Dr. Sangeeta? Yeah. Dr. Sangeeta, do you want to add something to this?
Ma'am, please, it was not audible to me.
Yeah, Dr. Sangeeta, do you want to add any comments? Do you want to?
No, ma'am, I just wanted to give a message to all postgraduates. So whenever you get a case of any case, is it uveitis or not, we have to go in depth, take the history from the patient. What I am seeing right now, all the postgraduates are not interested in taking the history. The history plays a very important role for any diagnosis. So many things they miss while taking the history, as well as proper examination, and then going for the differential diagnosis, which is very much important as a beginner, as a postgraduate.
Thank you so much. That was a very good presentation, exhaustive presentation by Dr. Gizala, combining all the ophthalmic elements. I would just want to her to just tell few words like how she felt presenting this and how useful or how did she find this as a good platform, or how did she find this presenting in this particular platform. Let us hear from her.
Ma'am, it was a good exposure for me to know how to present and what all to be considered to present while taking a case history, what all to look out and how to rule out causes. Like, and
Did it take away your
I was
fear?
able to ma'am, more concentration on
Confident.
history taking. Yes, ma'am, confidence also. Like it is a big platform for me to presenting. So I thank you all for providing me this opportunity to present.
You did well, Giza.
Yeah.
Ma'am, I just wanted to know she had been appointed a mentor for the last UVITIC Society competition. She had a very good exposure there also. She has been guided by the UVA specialist for all this.
Dr. Parthoprim.
Yeah. Good.
Very
Yes.
nice. Very nice. Congratulations,
Dr.
Gisela.
Thank you. Thank
Congratulations,
you.
Dr.
It was a
Gisela, very
learning
good
for us as
presentation,
well.
and
Soumya ma'am, this was
your
a learning
graph of
platform for us. Yes.
Dr. Mahesh sir,
Dr.
your
Gisela,
comments
very good.
please and vote of thanks.
Yeah,
Yeah.
yeah, very good presentation, Dr. Gisela, and I can
Thank
make out
you.
your graph of confidence has gone up from the initial few
Yes, sir.
minutes to, as we went ahead with when we conclude this session. And I hope you
Yes, thank
benefited,
you.
and I hope all the postgraduates who are joining us, who will be watching in future also are getting benefited. Okay, and
Thank you.
so we want to continue this, and we request all the medical college faculties to come forward and contribute it in whichever way they want. We want to continue with the undergraduate sessions also, exam-oriented sessions also, sessions with respect to stress management and other financial aspects. So many things which will be useful for our postgraduates as well as undergraduates, including research also, which is again close to my heart. So from my side, I thank all the my mentor Dr. Sangeeta, then chairperson Dr. Vasanthi madam, and all the discussants, and my co-moderator Soumya madam. Thank you, and closing remarks from Soumya madam. Over to you, Soumya madam. And one more
As we
thing,
come,
can all of
yeah.
us switch off the camera? Oh, madam, can all of us, can we be on camera so that we can request all? Uma madam. Uma madam is there? Uma madam is
He
not
left,
there,
He
I
I
is.
think.
think. Yeah,
Uma is left.
yeah. Okay, okay. Just for the sake of documentation,
Photo.
some memories of the session. Yeah,
Yeah, we
1 minute,
also
1 minute.
thanks Mahesh and Soumya madam for giving this opportunity. And it's a mutual learning as the journey goes for all medical college faculties. So we are very happy to be part of this program. Thank you.
Thank you so
Thank
much. So, as
Thank
we
you.
come to the close of this second session, it is my privilege to express our sincere gratitude to everyone who made today possible. First, I thank our chair, Dr. Vasanthi Madam, and co-moderator, Dr. Mahesh Babu, for steering this session with clarity and academic strength. My heartfelt appreciation to our mentor, Dr. Sangeeta, who instilled confidence and encouraged Dr. Gizala to present such a difficult case, which is a feast for such eminent postgraduate examiners. So, and my thanks to Dr. Hemalata, Dr. Uma Madam, Dr. Niharika for elevating the discussion through thoughtful questioning and insightful guidance. So, this kind of engagement is exactly what we aim to foster across the state. And a special word of appreciation to our presenter Gizala. It takes preparation and confidence to present before a statewide audience. So, and you have set the tone for future postgraduate participants. And I also thank all the
thank you.
postgraduate students and the faculty who have joined us online. So they would have had a knowledge feast today. So this would determine the impact and sustainability of this initiative. Finally, I extend gratitude to our digital partners, Clarnet, Swastika and Ritu, for ensuring smooth execution of today's session and having helped us plan this session. Today was more than a case discussion. A collaborative effort of KUPOTA is taking shape to harmonize the postgraduate ophthalmology training across Karnataka. So, if we continue with this consistency, this platform can truly transform how we teach, learn, and mentor. Thank you all once again. Looking forward to see you at the next session and have a pleasant evening. Thank you, everyone.
Thank you.
Thank you, one and all.
Thank you, ma'am. Thank you.
Thank you,
Thank
ma'am.
you.
Thank,
Thank
thanks
you.
a
So
lot.
thank you so much to all the increased present here. Clarity is really glad to have all these brilliant people together in session today. And I really hope that you all had a seamless experience. So with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you.
Thank
Thank you so much. Thank you.
Thank you. Bye bye.